Coding and Reimbursement here at Wolters Kluwer. And joining me are my colleagues Lee McMillan, Senior Product Marketing Manager, and Christina Panos, Manager for Customer Success and Product Development. Throughout today's presentation, we will take questions. We will address all questions at the end of today's presentation. There is a QA box to the right of your screen. Feel free to put those in, and I will look through those throughout the presentation. All lines have been placed on mute. There are handouts associated with today's presentation. If you look to the right of your screen, there's a link to it to the right of your chat box. There are also CEUs associated with today's webinar. There are CEUs from the AAPC as well as AHIMA. Sometime on Monday, you will be receiving those once you download the survey from today's presentation. Now it is my pleasure to introduce you today's speaker. Today's speaker is Christopher Richards. He is a Senior Associate at Barry Libman Incorporated. He offers his expertise as a former Medicare contractor to assist healthcare providers in better navigating a complex regulatory landscape. He has comprehensive understanding of the federal Medicare program rules and regulations, as well as extensive experience ensuring that clinical coding and DRG assignment results in accurate provider reimbursement. Without further ado, it is my pleasure to introduce to you Christopher Richards. Christopher?
Thank you very much. I appreciate that introduction. And it's a pleasure to be able to do this presentation on behalf of Wolters Kluwer. And hello to everyone out there. And this is just as means of sort of quick background. I have a 27-year history working with the Medicare program, and that is really where most of my healthcare background comes from. And it gave me a wide variety and a wide access to sort of what was going on nationally. And it has led a certain focus to this particular presentation on physician queries, which has, as we get closer and closer to I-10, and I will kind of angle this presentation a little bit towards everything that's coming with ICD-10, but that will allow me to kind of focus it. And I have been amazed at how many people now have expressed an interest in understanding and kind of fine-tuning the physician query process and how ICD-10 is going to impact that. So with that said, let's get going. The learning objectives today, what I'm going to try to do is essentially evaluate and help you evaluate when to query physicians. That's where this process also starts and ends, is an understanding of when. I want to describe a compliant physician query. I want to be able to identify the key guidelines for an effective query. I want to determine when to issue both concurrent, retrospective, and I'm also going to talk about post-bill queries and give you a little history of my exposure to that part of the process. That's always a question that pops up is, you know, how long after a bill's been dropped do I still have an opportunity to go back and query a physician? And so we'll talk about that a little bit. And then kind of top of the list, really, in terms of importance, is describing the steps for a compliant query, because this presentation really is going to focus and help you understand what is a compliant query and how do I not get into trouble by doing things that introduce new information, lead the physician. These are all things that we're going to cover during the next hour. So why do we query physicians? In the first place, you have to realize that everything in our job, and I'm sure that the audience may be a mixture of people with different roles and healthcare roles. I'm going to guess that a lot of folks out there are doing coding and looking at the records and coming up with the decision process of when to query and when to get additional information. So given that, the focus of this really is on a complete understanding that documentation is king. It's what you need. You need the documentation to translate into coding and coded data that can be submitted and reimbursement can occur. And that's where it all starts and ends. And it's the querying process is a vital part of that documentation process. What is a physician query? If we really want to just summarize it, it's a communication tool to improve the accuracy of the coding by actively involving the physician in getting clarification and completion of any documentation that may not be specific enough for you to do your job. And it also is, it's going to present specific facts that are derived from the medical record, things you identify, and you will identify why that clarification is needed from the physician. Now, if you go to the dictionary, you'll find physician, and you'll find the word query. I don't think you'll actually find physician query in the dictionary, but AHIMA has offered up its definition of what it strictly feels is the actual definition of a physician query. And it is, a query is defined as a question to a physician to obtain additional clarifying documentation to improve the specificity and the completeness of the data used to assign diagnosis and procedure codes in the patient's health record. So that's pretty clear, pretty concise, and that in a nutshell is what we're all trying to do through this process. Let's look at a few query guidelines. We're looking at a condition or a diagnosis that's established already in the record, and that's important because one of the key things is that a physician query should not introduce new diagnostic information or clinical documentation. We're looking at things that are already established in the record, and we're clarifying things in order for you to get enough information to accurately code it. The second guideline I like to stress is that this is really designed to be for all payers, regardless of the impact on reimbursement. We have to look at this and think of it in terms of ways that we want to improve data quality and the quality of the documentation. And I emphasize that this is not just a DRG thing. Coming from the Medicare background, we certainly dealt with query forms with CMS, the Centers for Medicare and Medicaid Services, in the context of DRGs, but it is not in any way limited just to DRGs. In fact, query never indicates the financial impact. Now, this is kind of interesting because I can tell you I have seen queries that basically state a situation to a physician, maybe something to do with acute blood loss anemia. And they'll write right on the query form, this is the current DRG, and this is the weight, and this is the payment. If we add acute blood loss anemia, then the DRG changes to such and such, and this is the weight, and this is the payment. Well, I'm here, if there's any one thing that you take away from this, it's that we don't do that. You don't want to indicate the financial impact. We're not giving them, 3 cards and pick one that pays the most. We want to keep it focused, again, on the data quality. It is indeed a statement of facts. You're going through the record, you're finding information, and as we'll see as this presentation goes on, there will be facts that need clarification, and that's what we want to restate to the physician and get some feedback. As we move through this, the other really important element in terms of a compliance perspective is that physician queries need to be non-leading, and we will talk more about that. And then the last issue really is that what do we do with the documentation that's been clarified? And some people add it to progress notes, some people have addendums to discharge summaries, some people keep the queries on the record as an official part of the record. Those are all things we're going to talk about too. When do we want to query? Basically, you're going to look at a series of questions. Ask yourself, does the patient's health record have any conflicting information, any ambiguous information, any incomplete information, clinically relevant information that's not addressed, or any significant reportable conditions or procedures? Now, we never have records that have any of these problems, do we? Unfortunately, that's not the case, and this is where this process comes into play. But if you answered yes to any of the above questions, then the coder needs to think about whether or not a query to the provider might be an appropriate action. Good old coding clinic. This is a coding clinic question that was asked all the way back in 2000. It's still relevant today, even though it's 15 years old. It's a pretty general example of the kind of things that we're going to run into. A diagnosis of COPD on an anesthesia evaluation is signed by the anesthesiologist. No other medical record documentation exists stating that the patient has COPD. So should COPD be reflected by the attending physician in the body of the record, such as the H&P, in order to be coded? Do we want the attending physician to confirm what the anesthesiologist has said? Because nowhere else in the record does it seem to speak of COPD. So this is a question that was always kind of, half people would think, oh, you need the attending physician to corroborate that. And other people would say, oh, the anesthesiologist can say that. Coding Clinic in 2000 answered it this way. They said it would be appropriate to assign 496 COPD. The anesthesiologist is a physician, and coding is based on physician documentation. However, if there is conflicting information in the record, query the physician for clarification. Coding Clinic has become famous for that statement. In the next slide, you'll see more. It is the responsibility of the coder to query the physician to determine if this diagnosis should be included in the final diagnostic statement. So they're basically saying that the anesthesiologist is a physician. You can code physician documentation, and you may not absolutely need the attending physician to corroborate that. Now, as I mentioned, coders in the coding clinics, we went back and looked through a whole bunch of them, and we actually we queried the word query, and we came up with 50 instances in the AHA coding clinic where they suggested that you query the physician for additional information. It always sort of seems to be their out. If they don't have all the documentation they feel they need to have to answer a question, they always sort of say, when in doubt, query the physician. And there are examples of when it would be appropriate to do that is, of course, to seek clarification if the documentation is ambiguous or if there's conflicting documentation. And we sort of already mentioned some of these, and we're going to mention them a little bit more as we go through this. Challenging handwriting. Has anybody ever seen anything that looks like this? I think in my life I've reviewed something like 50,000 medical records, and this writing is actually pretty good compared to a lot of what I see. I can't read it, but it looks more like words than some of the things I've seen. But this is obviously an ongoing issue with handwritten documentation. Maybe as we move into electronic medical records, it will become less of a problem, although new problems are cropping up all the time. Cut and paste issues, documentation that's transcribed, issues like that. But this is going to focus at least on a handwritten note and the issues that we face with challenging handwriting. Why is this important? Basically, legibility issues get into issues of medical, legal, and risk management and that whole fun realm of healthcare. Illegible entries in a patient record can cause legibility. You run the risk of having that kind of communication and handoff of information fail. This obviously can result in serious patient injury. If there are issues about drug doses, things like that, you could run into trouble. Without stressing the reimbursement issue, certainly if you're going to be missing a lot of stuff because you can't read it and can't documented in terms of the coding side of things, then you've got issues with reimbursement. Very important, though, is the legal viability. Will the documentation that you have hold up in court if it had to? And lastly, obviously, for data collection and reporting, you can't proceed with that aspect of the coding process and the reporting process if you can't read and document what's going on. Now I'm going to kind of pivot into some examples, and we're going to kind of use this as an opportunity to clarify what's a good query, what isn't a good query, and how we might tackle certain things. A lot of times in queries, you're going to come across information and you're going to have a sense of what needs to be documented, but you're going to realize that it's not there, and you're going to have to ask yourself, you know, is this an appropriate time to query, or can I work around this somehow? The four areas really that we want to go through are completeness, clarity, consistency, and precision. Completeness. When we talk about completeness, we're talking about things that are missing, things that are incomplete, missing test results. An X-ray report's available, but the provider doesn't document the abnormal results. All right, so you have information that's not documented by the clinician. That's important because the other way around is the different situation, and we will address that in a little bit, and that's not the same scenario. But missing test results. The next thing here, progress notes are missing. You may be trying to scramble at the last minute and say, where, you know, this is not all the progress notes. I'm missing, you know, Thursday through Sunday. What's going on? Where is it? We are running these days into a lot of issues with short stay summaries. The discharge summary guidelines versus short stay summary guidelines are a little different. We are in an era where we're evolving from a one-day kind of overnight meeting inpatient criteria, very ambiguous kind of decisions about admission as an inpatient versus treatment as an outpatient versus observation. There's the 2 midnight rule, which is in place now, but is sort of in flux because it's not being fully monitored by outside auditors yet, but maybe soon. But those short stay summaries may or may not appear quickly on the record, and on a short stay inpatient, you're going to need that because that's going to be virtually one of the main documents you have to code a record. So that's sort of a little summary of what I call completeness. Now, completeness with missing documentation, it is not necessarily an immediate issue for querying a physician. The coders must simply address the record as incomplete and start working as they do to assemble a record and get all the information together and all the documentation that may be out there and acquire that missing documentation that needs to be present in the record. It's not the physician's fault necessarily if the short stay summary isn't on the record. It's the physician's fault if he hasn't dictated or written a short stay summary. But there's a difference there. So completeness really starts with getting the record assembled and getting all the information that should be available in the record so you can start the coding process. Unaddressed documentation. Now, documentation that exists in the record yet is unaddressed. This certainly may and could be a situation where you do want to have a query sent to the physician. Unaddressed findings such as abnormal labs, x-rays, suggestive of diagnoses. These are the kind of things that need to be discussed with the clinician, and you have to establish whether they are significant. And if so, then they can be coded, and if not, they may be coded, but they may be coded in a different manner. Here, obviously, the physician query may prove very useful. All right, let's look at what I call clarity. And these are, the diagnosis may have evolved from a lesser to a more significant condition. A diagnosis is documented without documentation of a cause or a suspected cause, or there's no clinical validation. Clarifying a potential cause and effect relationship. This is something that comes up all the time, and as we move into ICD-10, there are some shifting guidelines in terms of cause and effect and what's presumed and what isn't presumed and what has to be stated as a causal impact. Anybody who's been coding for a long time knows the example of renal disease with hypertension. There's a presumed cause and effect that exists in that situation. When we have CHF, on the other hand, and hypertension, coding guidelines tell us that we need a causal relationship to be documented before that can be coded as hypertensive heart disease. So these are the kind of things you got to keep in mind as you're going through a record, and these are the kind of things that could lead to a query. Present on admission, the POA guidelines. If there's a determination that can't be made from the diagnosis with the current provider documentation, this is something that clearly is going to become very important in terms of identifying whether these conditions are present on admission or whether they evolve subsequently. They impact the hospital-acquired condition guidelines. They impact whether or not a legitimate complication or a major complication counts in the DRG. If it's determined to have been acquired after admission, it may not impact the payment whatsoever. It may be deleted from that calculation in the DRG grouper. That's certainly for the Medicare charts. Let's look at an example of a clarity issue. And you'll probably, as I read this, you'll see where I'm going with it and what as a coder, you're starting to think. A patient's admitted with pneumonia. The admitting history and physical exam reveals a white blood count of 14,000, respiratory rate over 20 at 24, a temperature that's up there at 102, heart rate of 120, hypotension, altered mental status. Patients administered an IV antibiotic and IV fluid resuscitation. Now, in this instance, you may have a physician who's diagnosed and written that the patient has pneumonia. And we know from this kind of lab work and this kind of a picture of a patient that's pretty sick, it's begging the question, does this patient have sepsis? And should the sepsis or the septicemia be the principal diagnosis rather than pneumonia? So here's how you want to write a query, again, in the form of a question, and ask for that kind of clarification. Based on your clinical judgment, can you provide a diagnosis that represents the below-listed clinical indicators? In this patient, admitted with pneumonia, the admitting history and physical, and I won't read this all again, but you've got the white count, the rate, you give them the facts that you've just picked up. You restate them, put them in the form of a question, and then ask the physician to please document the condition and the causative organism if known. This is an example of consistency issues. Consistency issues pop up when you have differing diagnosis between two or more providers, or you have documentation of clinical indicators, diagnostic tests, treatment, but no relative condition documented that's consistent with those findings. So you're looking at it going, I think, this is looking like one thing, but I've got kind of documentation that doesn't quite come right out and say that. And again, you're in a situation where you're trying to get that clarification without putting words in the physician's mouth, but you've got to restate the facts and try to get him or her to document what is relevant. And here's an example. We've got a patient that's admitted with chest pain radiating through the middle of his back. The provider orders multiple tests to rule out cardiac diagnoses. They are ruled out. Everything comes back. They do serial enzymes, all the tests, all the usual tests, and there's no evidence that the patient's had a myocardial infarction or anything else. Chest pain is obviously seemingly due to something else. On day 2 of the stay, the provider orders that the head of the bed be raised, hold the coffee, hold the fatty foods, and they put the patient on a 20 milligram dose of omeprazole or some form of proton pump inhibitor and cut that acid down. And on day 4, the patient's symptoms subside and they're discharged home. But there's no diagnosis documented by the provider other than they admitted them with chest pain and treated them. So again, this is one that you're sitting there going, well, this sounds like the patient did not obviously have a cardiac condition. So I'm leaning towards that this guy's got sort of gastritis or esophagitis or esophageal reflux or something along that line, and it's just not documented. Remember that in the coding world, you know, coders are allowed to go after technical coding issues and following coding guidelines and all those other fun things that I'll sort of touch base again at the end here. It's the narrative statements that appear in the records that you may have issue with, and those are the issues that you as coders can't change a narrative term. You know, you can't change pneumonia to bronchitis or CHF to COPD. Those are the kind of statements that if they're in the record one way and you think they could be another way based on other documentation, that's when you've got to think about asking the physician to draw some conclusions and help you out a little bit with those issues. So here's a consistency query. Based on your clinical judgment, can you provide a diagnosis that represents the below listed clinical indicators? And again, you're going to go through and look at the issue that the patient was admitted with chest pain, cardiac testing was negative, they ended up putting them on a diet and omeprazole daily. That certainly starts to beg the question that there was some sort of gastric heartburn or something along that line. So again, you ask the physician, form of a question, list the facts, and say, please document the condition and the causative organism if known. Next up, precision. When we look at the documentation of an unspecified diagnosis, and you have clinical reports and clinical documentation that is noted and is suggestive of a diagnosis subject to greater specificity. So you've got some information, you've got the right diagnosis, you're not arguing about what the narrative description is, but the code book allows you to go out and assign some very specific 5th digits or whatever, and that's where you've got, well, I don't know what the 5th digit is or what I can assign there. So you're requesting further specificity or the degree of severity of a documented condition. And the example that we're going to come up with here is one that everybody has probably wrestled with forever. Well, ever since they at least changed some of the guidelines and added these new codes. And that's good old CHF. A patient's admitted for right hip fracture. The history and physical notes that the patient has a history of chronic congestive heart failure. A recent echocardiogram shows a left ventricular ejection fraction of 25%. And being the clinical whizzes that we all are, we know that an EF of 25% is pretty low. The patient's home medications include metoprolol XL, lisinopril, and Lasix. So we've got chronic congestive heart failure listed here. We even have the fact that the patient has a history of chronic congestive heart failure. But the information that you're finding in the record is suggestive that this might be an acute flare of a chronic congestive heart failure. It may be decompensated CHF. We don't know anything from the echo about whether it was systolic or diastolic, and those are information that we need to assign a valid, 5th digit for the CHF and get the right CHF code. So we put this in the form of a query, and we ask the physician that it is noted in the impression of the history and physical that the patient has chronic congestive heart failure. A recent echocardiogram, again, notes that the cardiac review of systems has an ejection fraction of 25%. Can the chronic heart failure be further specified as? So you're asking a question, but as I'm going to explain in a few slides, there are a few exceptions in terms of actually offering the physician choices or checkoffs or yes-no type of responses, and we'll get to that in a second. But CHF, with its specificity issue, the precision issue, is an example of this. We're going to give the physician some choices here. We're going to say, is this chronic systolic? Is it chronic diastolic? Is it both? Is it chronic systolic and diastolic? And then what we're also going to do, and I can't overemphasize this enough, is that we're going to give the physician a few outs, a few in the coding world, the not otherwise specified, so the not elsewhere classifieds. We want to give them the opportunity to not be sandwiched into one of the first three. We want to give them an opportunity to say it was some other type, that it literally, in his opinion, cannot be determined, or that the question you're asking is clinically irrelevant. You know, I don't think it's clinically irrelevant, but you still want to offer the physician some opportunity to basically kind of dodge the question a little bit or not answer it as directly as you might like, in order for the query to be compliant and remain up to the compliance standards that we are expecting. All right, moving into the next area is I'm going to spend some time talking about the timing of the query. But at this point, I want to turn it back over to Chris. She's just going to go over a little bit of the MediReg information and describe some of the offerings they have there. Chris?
Thanks, Christopher. Just give me one moment, folks, to change my screen. And so now, if someone can confirm, you should be seeing my Audit and Revenue Resource Center. Chris, are you seeing that screen?
Yes, I am.
Thank you. So the Audit Revenue Resource Center, which is the MediRegs product that I've just moved into, is our top-tiered product within our coding suite. It's our most comprehensive solution. It is peppered with coding content, tools and resources, calculators, and at this level it has advanced content from the AHA and AMA, CPT Assistant, the Insider's View, and the coding clinics as well. Our solutions are content management systems. At the top tier, we have libraries and collections of information to support your research needs, specific to the CMS, federal government, OIG, as well as other specific libraries like specific topic libraries or inpatient hospital libraries, for example. Because it's a content management system, we keep you abreast of what's changing in the industry. We provide daily news alerts to you as users, and those users are being alerted to changes in those libraries and collections. So as new information is being added to our suite, we're notifying you both on a federal and state level with daily news alerts in our Audit and Revenue Resource Center. Users can customize what they get in those daily alerts based on the libraries and collections they choose on their site. They can also set up specific searches to do research and establish very custom, very specific alerts that are specific to a specific project or a need that they may have at their organization. We also provide a federal newsletter. It's a weekly newsletter that summarizes the federal activity that's occurring in the industry. So we give you multiple ways through our learning features to keep abreast of what's changing in the organization or in the industry, as well as what is very specific and relevant to your organization. We also provide a number of coding resources. We have all of your code books, your current code books. If I'm dealing with any type of outpatient coding, I start with my Advanced Code Explorer because it's a research assistant. It's going to provide me coding information from the AMA in our code books. This is searching CPT, HCPCS, and ICD-9 simultaneously. It's allowing me to see all of my results right on page, descriptions, the I-9 results at the bottom of the page, and I can launch into the code books themselves from this page so I can see the specific instructions given in the code book as well. From a CPT perspective, we have some additional links. It's our coding catalog, if you will, for CPT will include all of your AMA descriptions, chapter and section guidelines specific to a given code, coding tips, parenthetical guidelines, as well as national payment information based on that particular code. In this example, OPPS, ASC, physician, etc. We also search all the transmittals, so we'll surface any issues found and communicated via transmittals specific to that code, and we provide links to each of the applicable transmittals, as well as local coverage decisions. So for the given code selected, you're being able to see all of the local coverage decisions for specific states that you're interested in, and see specifically the coverage decisions or coverage articles. In this case, there's some coverage articles that have been surfaced specific to the code of my selection. We also have a very robust library of coding guidance, and that guidance library includes various CMS resources, as well as advanced titles that I mentioned earlier in some of our products, being the AMA CPT Assistant, the Insider's View, as well as your coding clinics. So in using my Advanced Code Explorer, I'm searching all of the titles in this guidance library simultaneously, and in my results list, I'm being told how many hits I have, and I'm able to explore specifically the results for that particular collection. Now, in addition to coding and guidance and coverage information, I also have payment information on my screen, on the right side of my screen. This is adjusted to this. It's leveraging two of our calculators, and it's adjusted to the localities or specificity of the hospital. So I'm seeing adjusted payment rates here. I can actually launch my APC or my RVU calculators to do more specific searches beyond just a single code. So this is giving me my single code reimbursement, but if I wanted to run a whole claim scenario, I could launch my APC calculator and simulate a claim by entering multiple CPT codes. In this case, I've just pulled the one from my Code Explorer as an example. Beyond the Advanced Code Explorer, we do have additional coding resources. We have all of your current code books, direct access to titles like your HA Coding Clinic for both CPT, HCPCS I-9, and I-10. In our top-tiered product, we have the ICD-10 Handbook and the AMA titles, CPT Assistant, and the Insider's View. Your current code sets are all available in our ICD-10 books, and in all of our code books, really, we're placing the official coding guidelines, so we're making those available within the code books as well. From a physician coding perspective, we have E&M guides, so we're giving you information that's been accumulated from various contractor websites and other agencies specific to evaluation and management coding, audit reports, guidelines, etc. So that's a really valuable resource. We are completely ICD-10 ready, so beyond the code books that I've showed you, we've created an entire workspace for ICD-10 where we've accumulated resources that we've written, study aids, white papers, the regulations, as well as giving you another place to access all of the coding resources, which include an ICD-10 Code Explorer, the code books, and the handbooks. Now, from an inpatient payment perspective, we do have a DRG calculator, which is quite a wonderful feature. That's going to allow me to group and calculate a claim, so I can use my grouper as well as calculate simultaneously. I can do this for a national unadjusted or for a specific facility. We have specific fields that do require some entry, some key fields, but once I've entered in my diagnosis and procedures, then I can group and calculate that claim or that scenario and surface what DRG that particular scenario falls into and what that payment rate would be. In this case, I did an unadjusted national rate, so I'm seeing a national payment rate as opposed to a facility specific. We also have the ability just to calculate for a specific facility that I might choose. I'm just going to select one from my list, and I can enter in a couple DRGs and calculate for the time period of interest to see multiple DRG reimbursement rates adjusted for a specific facility. I can also show it in a summary format, which is a nice visual when I'm looking at the impact of a diagnosis to a DRG. I can see what that impact to the payment will be with or without a CC, for example. So those are just some of the resources that are available in our coding suite. Again, I've showed you the Audit Revenue Resource Center, which is our top-tier product in our coding suite, but we have multiple product offerings that support the needs of multiple professionals across the organization. So I'm going to turn the program back over to Christopher so he can complete his presentation. And Christopher, you should have control momentarily.
Okay, I got it. Thanks, Chris.
Excellent.
All right. I'm going to go back one slide. I just wanted to, at the end of the precision query, when we use this example of congestive heart failure, I just want to point out that as we transition into ICD-10 and ICD-10 CM and PCS, you have an opportunity as you get closer to implementation on October 1st, 2015, which, barring any last-minute whatever's, is going to be a pretty firm date this time. I'm 99% confident that this is happening. But you have an opportunity to take some of the difficult areas where you've had a hard time getting physicians to document what you need and kind of use the transition to I-10 to get them aware of this, that, you know, you can even, I'm not saying make things up, but I'm just saying you can take some of those tough areas and you can talk to the physicians and say that this is going to be really important in ICD-10, that you're specific and you focus on these areas. So you can almost use ICD-10 a little bit to help fix some of these documentation issues which have been a thorn in your side for who knows how long. So that's my little sidebar on that. All right, I want to talk about timing of queries. There are really three opportunities here. There's what we call concurrent, retrospective, and post-bill. Concurrent, defined really as a query that's issued while the patient is still in-house. This happens in real time. It encourages timely, accurate, and reliable responses from the physicians. It generally occurs on the floors. There are CDI people, the clinical documentation improvement folks, that are up there working with the physicians, looking at the trends and tendencies in the clinical documentation to make sure that they don't pick up things that seem to be incomplete or ambiguous. And those are the examples really of a concurrent review. And what's nice about this is that they're able to, command the physician's attention right there, and they can get into the record right on the floors and add things and document things. So a formal query piece of paper, for example, may not ever exist in this kind of scenario. You're really fixing and capturing things in real time. And it's a good way to have it all come together, to be honest. The next example is what we call retrospective. This is probably the vast majority, I would have to say, of query and query situations. They basically are initiated after the patient's been discharged, but prior to the bill being submitted. So this is during the coding process, and you're getting the case ready to be billed, but you're coding it, and you're going through all that documentation, and you're assembling all that missing information we talked about, and then making decisions about whether or not there's anything that's confusing that needs to be clarified. It's effective in cases that have additional information available in the health record. Short stays, we talked about that. These concurrent reviews may not always capture these patients that are in and out real quickly, especially the ones that now are starting in the emergency room. They may get transferred very slowly up to the floor. They may go to a special observation unit. They may even get parked in the hallway for a little while waiting for disposition. But these people sometimes can get lost, and the documentation you need may not always be in the record. So a retrospective query can stem from that information quite easily. The other example is when concurrent queries just aren't feasible. And this may, again, be just because of the nature of the short stay and the concurrent piece may not have gotten communicated to the right physician. The patient may have gone home before the physician came back in. Those kinds of scenarios. Post-bill, my favorite area. From all my years working, I worked as a contractor for CMS, as I mentioned, it was almost 30 years. I was heavily involved in the whole evolution of the DRG system, every documentation scenario you can imagine. And one of our responsibilities was to evaluate higher weighted DRG adjustments. So again, without focusing entirely on reimbursement issues and DRG issues, because as I said, this whole physician query thing is not a DRG thing. It's a documentation quality, documentation improvement process. But what happened at the QIOs, we looked at hospitals were allowed by federal regulation to resubmit bills within 30 days that they were initially paid. In other words, they received what they call the remittance advice, which indicates what DRG they got paid. The date on that remittance advice, the clock started ticking. And they had 30 days to resubmit that bill if they found additional information, if there was an error. Sometimes it was a technical thing, a procedure got truncated, dropped off the claim and didn't show up, so the wrong DRG was paid. And the hospital had 30 days again to resubmit those bills. And they basically submit the claim with the new coded data. It goes through the fiscal intermediary, the administrative contractor, and they were instructed to basically validate the time frame and then reassign the case to the new DRG and reprocess the bill. And then what would happen is that every time that happened, the case would get sampled by CMS, picked up, and they'd look at it and see if it went to a higher weighted DRG. In other words, there was more money involved. If it did, it got plucked off of their list and sent on a documentation sheet form to the Quality Improvement Organization, the QIO, where we would then request those records from the hospitals and do a review. We had the old DRG and the new DRG, so we basically did a validation process to see if we agreed with the new requested payment level. And in addition to that, though, we also looked at the appropriateness of the admission, whether it met criteria to be paid as an inpatient claim, and it also opened the record up to quality of care review. So, you know, I can't tell you how many times we agreed with the DRG upgrade, but we found something with the quality of care, or we disagreed with the admission and we ended up denying the entire claim. Physicians would review these and say, you know, that patient should have been treated as an outpatient. It became a problem. And what we did at the QIO is we kind of monitored also how often hospitals were rebilling and submitting what we call these higher weighted DRG adjustments. And most of the hospitals would do it once in a great while. Some hospitals would do it, you know, one case a month. A few hospitals, maybe 2 or 3 cases a month. And then there were the hospitals that would submit 10, 15, 30 a month. And it was clear to us that what those hospitals were doing were, after the bill was dropped, they were going through those cases with a fine-tooth comb and finding additional secondary diagnoses and additional major complication codes. And then they may have been at that point querying the physician and finding out if it was okay to add that as a code. And if they got the go-ahead, then they would rebill it. And we used to basically, after a while, we turned the tables on the hospitals and said, basically posed the question, you know, if you're resubmitting so many bills with bad initial coding and you're rebilling them with better coding, then, you know, your initial coding must really have some issues. And under the threat, not threat, but under the you know, the concept that we might be interested in maybe intensifying your initial review and find out what the problems are with your initial coding. Well, guess what? That usually got their attention, and all of a sudden these audits and these bill reviews went from post-bill to retrospective. And I just want to emphasize that if you've got a facility out there that is doing a post-bill audit, that you do want to be careful not to oversubmit post-bill claims and not to evoke the post-bill physician query too often, because it just exposes the hospital to a lot of unnecessary review. And in a healthcare era where we're trying to be efficient and save taxpayer money, this is an incredibly inefficient way to rebill. You've got the QIO involved, you've got the Medicare administrative contractor involved, you've got CMS involved, we're requesting records, we're getting records sent to us. It's just very, very inefficient. And I really won't go on any longer than to encourage people to do their audits, but to try to do them to the degree possible post or retrospectively, and save the real genuine kind of mistakes for the post-bill process, okay? Now I want to take a minute and talk about when not to query. You do not query to question a provider's clinical judgment. You want to ruin your physician query process? There's no faster way to do it than to do this. As an example here is a chest x-ray is negative, but the provider documents clinical pneumonia. So you write a query to the physician saying we should we not include pneumonia on the claim because the chest x-ray was negative? Well, you're going to get an earful, and that is something that we just want to steer clear of. The physician's documented it. Even if you disagree, you know, it's not your call. It's the clinical physician that's going to make that judgment, and his record is going to stand by his opinion, and he can argue that to the powers that be. You do not query when the benefit is strictly for reimbursement. Now, this requires just a little bit of a sidebar, because, as I said, with the DRG issues and the all-payer issues, the intent of the query is not to go digging for reimbursement issues. That said, this program had a description that said basically coders have a fiduciary responsibility to make sure that their payments are optimized, that they're correct and accurate, and that the facility gets all of the dollars that it's legitimately entitled to. So in many instances, it's hard to say, on the one hand, the HEMA has said, you know, don't query if the benefit is strictly for reimbursement. On the other hand, if you have a really legitimate issue and it results in higher reimbursement, you know, don't shy away from asking the question and bringing it forward. You just want to be careful that the physicians aren't kind of getting a sense that every time they get a query, it's, you know, oh, you're just asking me this because you're trying to get more money. I know. Tell me what to write and I'll write it. You know, they get a little query weary of, you know, of those kinds of questions. So it's just kind of a little bit of a heads up there. You don't want to query for just clinically insignificant findings or irrelevant information. Every facility has its own guidelines of what it wants to capture, what it wants to report, and you've just got to be cognizant that you don't want to go nickel and diming every little thing. It's fine if you want to submit them as part of the claim, but be careful when you've got a really minimally important issue. You don't want to be bothering the physicians with those kinds of clarifications. Basically, if you can skip it and do without that issue or raising that issue, I suggest you do that. How to query. This is just a slide that basically is going to help hospitals that are fine-tuning their query process to just be cognizant of what the query form itself should look like or what kind of information it should contain.
I like to see at the very minimum the patient name, the admission date, the medical record number, account number if you've got it. The date of the query is very important. You want to get that date down there because that comes back to be very helpful. If there's delays in getting responses, you can point to the date you asked the question. It's just a very critical piece of information that you should have on every query. You should have the name and the contact information of the coder or the clinical documentation improvement specialist that did the work or raised the question. And then clearly is the section for the statement of the issue and the restatement of the facts and how you're going to phrase that question. All comes down to really this last thing, the statement of the issue. Written as a question. That's very important. You don't want to make this a statement. You want to ask it as a question, but you want to then include the clinical indicators from the chart, state the facts, ask the practitioner to make a clinical interpretation of the facts that you found in the chart. The query format should not sound presumptive, directing, prodding, probing, or as though the practitioner is being led to a certain diagnosis. I'm going to say that again. Being led to a certain diagnosis. Okay, a query doesn't do that, and if it does do it, you're going to get into questions and issues with leading queries. How do we avoid leading queries? Per the American Health Information Management Association, who have really taken the helm of being the experts on the query process, them together with CMS and some of the QIO activities, they've looked very closely at what is and what isn't a good query. And per AHIMA, their definition of a leading query is a query is never intended to lead the provider to one desired outcome. The query must provide reasonable, clinically supported options, include clinical indicators, and must not result in a yes-no answer, although I'm going to talk about that in just a second. The query must include the option that no additional documentation or clarification can be provided. Again, that last sentence is very important. Always give the physician in the query process an out, that opportunity to say, there's no answer that I can give you on this. You're just going to have to take what you've got and go with it the best you can. And that's fine. If that's all we can do, that's all we can do. Now, on the yes-no queries. In general, queries should not be designed to ask questions that result in a yes-no response. There was always along the beginning an original exception, and that had to do with the present on admission queries. When a diagnosis has already been documented and you're asking the physician, was this condition present on admission? And you were allowing him to answer that question, yes it was or no it wasn't. Or as some of the other nomenclature for capturing POA information, undetermined and not enough information, those kinds of options. But later on, as they looked at this a little more closely, and especially with the precision issues of, specificity and fifth digits and those kinds of things, AHIMA decided that it would write up in its documentation that 3 additional exceptions were considered acceptable. Substantiating or further specifying a diagnosis that is already present in the record was one example. Establishing a cause and effect relationship between documented conditions such as the manifestation, etiology, complications, conditions, diagnostic findings. This all gets into the cause and effect. Was the complication post-operative? Was it due to the surgery, or did it just happen inadvertently on its own? The manifestation, underlying cause. The example I had about hypertension and CHF. Those kinds of questions could be posed to the physician. Again, as long as you're asking it in a question, stating the facts, and then asking him to say, is this a cause and effect, and should these be coded as that kind of a causal relationship, yes or no? That was considered to be acceptable. To resolve conflicting practitioner documentation is the other example. In all yes-no cases, provide an other option. So even when you're asking something that can be answered as a yes-no, you want to leave an other line or category or an area for the physician to write. So again, that he isn't, or he or she is not forced into asking or answering the question, rather, with a yes-no response. They always want to have that other option. Now here's a beauty. Let's look at this example of a leading query. And this is a slide that you want to maybe post somewhere that's a good example of what not to do. Dear Dr. Jones, based on your documentation, this patient has anemia and was transfused 2 units of blood. Also, there was a 10-point drop in hematocrit following surgery. Please document acute blood loss anemia, as this patient clearly meets the clinical criteria for this diagnosis. That is not how you want to do a query. That is something that an auditor, a quality improvement organization, CMS, even your other payers are all going to say that if that's left on a record and someone sees that, they're going to say this is about as leading as you can get, and they're not going to be real happy with that use of that kind of clarification effort. Query policy and procedures. Every organization is going to have a policy and a procedure about how they're going to address the following aspects of the query program and the query policies that you develop. One is, sort of 1 and 3 really deal with the same thing, the format and the templates. You know, you're going to have a format that's going to include some of the elements I talked about earlier. You're also going to potentially create templates for different clinical situations. You may have a template just for CHF. You may have a template just for excisional and non-excisional debridements. You want to develop the queries so that they're consistent, that they're in the format we talked about where they ask questions, relate to facts, and give the physician options for other, and work with the templates in the format in that manner. Frequency has to be addressed, and I'm going to talk a little bit about this in the end in my kind of summary. Non-compliance really relates to what do you do when you ask a question and you don't get a response. You ask it again and you still get no response, and you're left with this chart that's kind of dangling and waiting for a clarification, and it's just not happening. The policy has to, somewhere along the line, delineate what you're going to do in that scenario. You know, you're going to move forward with what you've got. Can you move forward with what you've got? Are you going to track who the non-compliant physicians are so that someone in the medical staff can maybe work with them? Lastly, maintenance is just that as a policy, you're going to have to revisit. Someone's going to have to revisit this. It's a fluid document. It's going to be evolving. It's going to have to reflect that and be adjusted and fine-tuned as time goes on. And more important than anything else, the policy must address whether the physician query form becomes a permanent part of the medical record or whether the physicians are required to clarify the query answer in a progress note or as an official addendum to the medical record. This is an issue that comes up all the time. Some hospitals say that, well, the query is left on the chart, it becomes an official part of the medical record, and that's valid for coding purposes, and everybody's fine with that. Other institutions say, no, we don't want that query, and we don't want it anywhere near being a permanent part of the record. We want to force the physician to write an addendum to his discharge summary or add it to a progress note, something along that line. So each hospital has to decide how are you going to handle that. There has to be a strict policy about what you're going to do with regard to this question and answer process once you have it in paper. Along the same lines, you know, there has been years of evolution between the Centers for Medicare and Medicaid Services and the quality improvement organizations. And they, after a long back and forth and involving a HEMA as kind of the arbiter, have now shown themselves to be okay with physician query forms in the medical record to the extent that it provides clarification and is consistent with other medical record documentation. And the one statement that wasn't included there, but I'll add it, is that it can't introduce new information. It can't go back to a previous, it can never go back to a previous admission and pull out documentation from that admission and bring it forward and say, you know, the patient had such and such last month, you know, shouldn't that be addressed and documented in this admission? No, no. You've got to have each admission has to stand on its own. And this will be very important going into I-10 because that's been clarified by Coding Clinic that, you know, that these are individual admissions and the documentation has to stand alone so that it communicates all that health information amongst the providers. Let's say that in summary, we have full awareness that the quality of the coding is dependent on the quality of the documentation. As we move into ICD-9 CM and ICD-10, CM and ICD-10 PCS, we are aware that this is going to become, you know, more of a challenge. More issues are going to come up where there's a question of whether there's enough documentation or we need to query. So we've got to be aware of that and open-minded and have a lot of people brought to the table to discuss when and when not to query. The query, again, is a communication tool between the physician and the medical staff and the coders and the billers and the CDI people who are putting together a quality medical record and a health information document. They are fact-based to clarify documentation and improve data integrity. The components include timeliness, language, and relevance. And the policies and the procedures that each facility develops are really the key to success. Those have to be updated and monitored and implemented. And physicians have to be held accountable once there are policies and procedures related to queries in effect. Now here's where everything is going to ride moving forward. Okay, one of the big issues with physician queries is query fatigue. You don't want to create query fatigue. Physicians are busy. A lot of them are going to be uninterested in this process. Some are going to be interested in this process, and some will actually take an active interest and be available and be quite, involved in this. But one of the ways to continuously foster a relationship with your physicians is to basically, meet them halfway, make them understand that you don't want to hassle them and make their job any harder. You realize they're busy. You want to respect their time. But you, again, have a role and a responsibility to get this information coded, reported, documented for all the reasons that we do coding. And we have to just, it has to be a buy-in from both sides. You've got to respect their time, but they have to realize that you have work to do that needs their input as well. One of the really good ways to get this accomplished is to have a physician advisor, a physician champion, an ombudsman, whatever you want, that is going to play a role of kind of an in-between person that can help you explain to the physician what's missing or what's needed, that can be that buffer for the physicians that are being kind of, stodgy and uncooperative. That's the query programs that I've seen work the best have a very valuable physician advisor that plays a role in between and kind of helps that process move along. Always keep the query open-ended, as we said. You've got to allow these physicians to document the specific diagnosis or check another box or elaborate in some way that may or may not be helpful, but that's at least, you're getting a response and you're getting some information that you can work with, hopefully. Good query forms even include a specific statement that explains, and I love this because I've seen this on query forms and I found it to be extremely helpful. It removes some of that sense that the physicians think this isn't about data quality, it's just about reimbursement. But the form at the bottom would actually have a statement in bold that says, the question asked does not imply that a particular answer is desired. It just right up front diffuses the whole leading query issue and the compliance issue, and it states that, look, we're not looking for you to give us the answer we want. We just need to get you the information that we found and ask for your clarification so that we can code it very accurately and precisely. If the query seems too focused on a desired answer, that's when you run into problems with people saying, well, this is kind of a leading query. And I'm the first to admit that you walk a very fine line, both in the leading and non-leading query issue and also the fine line about when to query and when not to query. So, this isn't easy stuff. Physician queries has been a headache for everybody for quite some time. And I hope through this program, this presentation, you at least come away with, some sense of kind of how to boil it down and make sure that you're doing everything in a compliant manner and getting the information that you need. You, the coder, CDI people, billers, anybody that's involved with these charts, utilization, case management, everybody may have an opportunity to pick something up that belongs in the record or needs to be clarified. But you, as a coder, should always be guided by AHIMA standards of ethical coding, as well as, and this is where, our work starts and must be comprehensively addressed before we even think about sending a query to a physician. You want to follow all the official coding guidelines. The I-10 official coding guidelines that were reissued in 2015. It's a 116-page document, nice bedtime reading, but you need to go through that and make sure that as a coder you understand where and how the I-10 direction is going, where the differences are. If there's not a heck of a lot of difference, the guidelines really pretty much stay the same with the, a handful of exceptions, but those handful of exceptions are important and you need to be focused on them. You want to use your AHA coding clinic guidelines, and by all the other thing that's the most important of all is really everything is dictated by the conventions of the classification. When you're coding and you're in the book and you've got excludes notes and includes and code alsos and not referenced here or see also, all of those things are your first area where you're going to have to make a decision about whether or not you can code this based on conventions of the classification, the coding rules, rather than involving a physician in that. ICD-10-CM and ICD-10-PCS, if you are mastering this process now for physician queries, then the transition to ICD-10 and PCS will occur far more efficiently. One of the things when it comes to PCS that's important to remember is that under the efficient coding guidelines for the PCS piece, it says that the physician is not expected to use the terms used in the PCS code descriptions, nor is the coder required to query the physician when the correlation between the documentation and the defined PCS terms is clear. When a physician documents partial resection, the coder can independently correlate that partial resection is a root operation excision They don't need to query the physician for clarification. It's up to the coder. It's the coder's responsibility to interpret the terms used in the PCS code descriptions. It's not the physician's responsibility to use the words that you want to code the record. So that's just kind of an important aspect too. These are your references. That Department of Health and Human Services QIP, that's called a Technical Operational Policy Statement, was issued in 2001, and that's the one that really cleared the QIOs and CMS and AHIMA to develop a process by which queries and physician queries could be used. You know, this all went back to a time period years ago where, you know, it was just thought that whatever the physician wrote, that was all you were going to get, and you had to go with that. But with the complexity of the coding system evolving, this idea of querying the physician for more clarification became more and more important. So these are some of the practice briefs, 2003, 2008. There was a documentation on clinical documentation improvement in 2010, and then some great physician query examples in 2013. So I encourage anybody with additional questions to seek out these references, and that should be pretty helpful as well. Before I just open it up for questions, again, I just want to point out that this query process is one that is important, but it's also really, really important to keep to a minimum. You don't want to be sending out queries so often that the physicians just shut down. You've really got to pick your battles. You've got to do the best you can with the records and the documentations and the rules and the guidelines and the conventions that you have, and do as much as you can with that information to come up with all of these codes and the specificity. But clearly, if you've got, you know, like in ICD-10, there's all this laterality. You know, if you've got to code either a right arm or a left arm and the physician hasn't said, you know, you can't, you have no choice. You can't make up a third arm or an arm unspecified. There is no arm unspecified. So you will learn with your physician team, your physician staff, and your liaison the kinds of documentation that has to improve, has to be included, and is going to be essential to get the accurate codes and help them do their job and help you do your job. So with that, I hope that was helpful, and my information is up here. If there are any questions that we can't handle during the Q&A period, I'm glad to take emails at that address and get back to folks, or I'm sure there's a process too where Wolters Kluwer can provide an email response with all of these questions that may arise or continue to arise over time. And with that, I thank everyone for your attention, and I'll turn it back over to Chris. Thank you.
Thank you, Christopher. This is Maria, and thanks for that's okay. Thanks for the great presentation. I learned a lot, and we do have quite a few questions from the group. With only 10 minutes left, we probably will not get through all of them. I just want to thank everyone for attending and staying with us through the presentation. Any questions that we don't answer, we will have Christopher take offline and answer those. And actually, all of the questions will be downloaded from today's presentation, sent to Christopher, and he will answer them and send them back to us, and they'll be available in our product. So for the first question, Christopher, let's see here. I'm going to go all the way up on top. Can you speak to verbal queries? For example, say a CDI specialist who catches a physician on the floor and asks about a patient's diagnosis. What are your thoughts about verbal queries?
This is what I lump into that, that category of concurrent queries, where you do have CDI nurses on the floor. And this is a process that's, you know, become very, very useful. You have certainly, you know, I see sometimes there needs to be a lot of cooperation between the CDI nurses who don't know as much about coding
And then there's always the issue of, the CDI people say the coders don't know enough about the clinical issues. So, that's a battle that's raged on and will continue. But the main issue is that when you're right there on the floor and the nurse catches something and can talk with the physician, then the physician just can incorporate that and agree and document it in the progress notes. And it's just like there was never really any discussion at all. It's like the physician agrees and had it there the whole time. There does not need to be a formal document or a formal process necessarily that speaks just to that scenario. You can have those things captured right then and there and put into the record, and no one's going to be the wiser. It's accurate and it's documented now, and let's move on to the next thing.
Great. Thanks, Christopher. Here's a question from Larry. Larry asks, if a condition was actually treated but not documented, what do you do about that?
If a scenario where something was treated, and this would probably get to the Uniform Hospital Discharge Data Set in terms of whether it qualifies as a so-called other diagnosis or additional diagnosis, in terms of what it required in terms of treatment, additional nursing and or monitoring, other studies that were performed, diagnostic things. If it meets the qualifications of being a secondary or additional diagnosis, you've got information in the record that documents that. That's something that really, I think, the coder can make a decision about whether it's appropriate to code that and report it. And if you agree, then I would code it. If you need additional documentation to clarify what it is that's been documented, then you potentially might be into a query situation. I hope that answers the question.
Yes, great. Thanks so much. Can you talk a little bit about the illegible, what if there's like missing or illegible documentation? Does that apply in the medical record environment? I personally don't think not, but I thought maybe I would ask you.
Well, I mean, if you're talking just about legibility, that's a concern. If you can't read, tried to kind of explain my point of view on illegible documentation. Certainly, if you've got a hint that there's something documented that's really important that you can't get your teeth around, and you just can't your teeth into them, and you just don't know whether or not it should be added or documented, you may have to go back to the physician and say, I just can't read this. I think you might be saying pneumonia here, but I'm not sure. It could say pleurisy. I just can't read it. That's important stuff to clarify. And that's also something that, every hospital works hard with their physician staff so that they can write in a manner that can be read by everybody. But not always the case.
Great. Thank you so much. Next question. I'm trying to get some that aren't so lengthy, Christopher, due to our time. In the GI example that you talked about, chest pain radiating to the back, if there were lab reports that confirmed gastritis, would you still query the physician?
The answer to that is really a sort of a long-standing issue and problem that we've always had, where according to all coding rules and guidelines, that we are not to code from lab reports. Now, that basically means that if the physician did not actually write somewhere in the record GERD or gastritis or esophagitis or something, and you've got a lab report or an X-ray report, you cannot code directly from that lab report. As we move into ICD-10, there are coding clinics which, and this is a great victory for coders really, is that they have established, coding clinic has come out and said that in ICD-10, you can use lab reports and x-ray reports to get more specificity. In other words, if you're looking at a stroke and you're trying to identify what vessel was involved, and the physician didn't say in the record, but the arteriogram or an MRI or something does specify specifically what vessel, then you can use those reports to establish that 5th digit, 7th digit, the specificity aspect. But the question itself is directed, itself towards a documentation issue and a diagnosis that's not documented, but a lab that is. That's where you're going to have to ask it as a question, present the fact that the diagnostic or that the laboratory or x-ray lists that diagnosis, and then ask the physician to clarify whether or not that diagnosis should be included.
Thanks, Christopher. Let's see here. Okay, here's a good one. Do you recommend a follow-up query if the answer is still not clear as a coder? And would you recommend a second query if there's no response in X number of days?
I think the reminder system, again, falls back to whatever the hospital wants to establish as part of its policies and procedures. Personally, I think if you get no response from the physician, you certainly should follow up and say, just to reiterate my query of, this is why it's important to date the queries. But sure, I would follow up definitely on a case where you just get no response at all. This brings up the point of the importance of getting the right physician, because sometimes you will ask a question with multiple hospitalists and attendings and surgeons and consults, and you got to get that query to the right person that has kind of created the ambiguity. Because if a physician gets a question that, this doesn't apply to me, you're less likely to get a decent answer if you get any answer at all. As far as ambiguous answers, this is a tough one because, your goal is to try the best you can to get a well-thought-out, well-written question to that physician so that you hopefully will get a decent answer back. If you don't, then again, your policies are going to have to indicate, to what degree you're going to kind of, harp on that physician to clarify something or to send a secondary query. You're beginning to open up, that can of worms where the physician's going to get query fatigue and say, I answered this. I said that I can't tell or I don't know or something. And that may be the best that you're going to get. If there is a fine line between what they answered and what you needed and just one more little clarification will put it to bed, then sure, I would try to the degree possible, reopen it and ask the question again.
Thank you, Christopher. Well, that sums up all of our questions that we'll have time for today. I want to thank Christopher Richards for doing a phenomenal presentation as Senior Associate at Barry Libman Incorporated. Thank you all for attending Documentation and Physician Queries in the Hospital Inpatient Setting. I do want to remind everyone, as a registered attendee, you will receive an email sometime on Monday from us. Please take the survey. We always want to know how to better serve you. And once you take the survey, you will then see the CEUs associated with today's webinar. Again, I want to thank everyone for attending and have a pleasant day.